Hello and welcome to South to North, bringing you the voices of the global South from Johannesburg, South Africa. To most women, having a baby is a beautiful and romantic thing. But here in Africa, it's often a matter of life and death. A recent African Union report shows that sub-Saharan Africa is trailing behind its 2015 Millennium Development Goals of reducing maternal mortality by 75%. Meanwhile, some poorer countries in Asia are en route to achieve theirs. So why is childbirth still such risky business in Africa? What's the secret behind other countries' success? And what does it take to give all women the luxury of looking forward to a healthy baby? With me, I have from Stockholm, global health expert, Professor Hans Rosling. And in the studio with me, Deliwe Nyatigazi from the International Confederation of Midwives. Also joining me later is UNICEF Chief of Health, Sanjina Bhardwaj. Welcome, Deliwe. Welcome to South to North.
Welcome.
Let's start with you, Professor Rosling. Let's talk about the Millennium Development Goal, reducing maternal deaths.
It's difficult to measure maternal mortality, especially the starting year, 1990. We have a very vague idea on how high maternal mortality is. I have a personal experience. I worked as doctor for the Minister of Health in Mozambique 30 years ago, up in Nacala in northern Mozambique. I was the only doctor 1 year for 300,000 people. There were 15,000 deliveries, and I couldn't do any cesarean sections. The cesarean sections were 200 kilometers away. Now I went back to Nacala just a year ago, 30 years later. Now there were 16 medical doctors there, and they were doing 300 cesarean sections each year. However, the population had doubled. Where we had 300,000, there were now 600,000. But there was an immense improvement.
You are known as the king of data. I understand you've brought some props to demonstrate the extent of maternal health in the world.
Actually, I like people, but I try to understand them through numbers. Now, what I have here in front of me is the world population. Look at my 7 props. Each one here is 7 billion. And this is the world population. This one is the richest. This one is the poorest. And these are the others in between. Now, these are the little more than 300,000 women that die every year in pregnancy and childbirth. 200,000, most of them, is among the poorest. Then the other big chunk is here, the second poorest billion. Then there are much fewer and fewer and fewer. It's skewed. And what do they need? Well, they need health service. This is the stethoscope of the midwives. This is what they need over here. It's the basis of a health service system. What do people in the middle expect here from the health service system? Well, tablets against hypertension, because here the start of life is secured. Now you want to live older. And over here, when already you have an old life, what do you want? Well, you get pain in your hip and you want a hip replacement. In my country, in Sweden, we do as many hip replacements as we do cesarean sections. This is successful Asia, this is Mauritius, this is parts of Ghana, this is Latin America. This is the Arab world, this is large parts of Asia. And this is the poorest, which is sub-Saharan Africa, except South Africa. And this is the poor rural areas of India, Bangladesh, and Pakistan.
Why is sub-Saharan Africa trailing behind when it comes to securing maternal health for millions of women?
It's lack of money and sometimes unwise use of that little money that exists. Many parts of Africa has sparsely populated rural area where transport is a big issue. This is very difficult. And also other types of infrastructure, the roads in themselves, and electricity. You need to be richer, and you need to use that money well.
Well, somebody who deals with this situation and finding out how people are affected by this on the ground, a midwife by training and currently serving as a social development official in a province not far from here in Johannesburg. Welcome to the program, Deliwe. It's lovely to have you with us.
Welcome.
Why are some countries in Africa trailing behind their poorer counterparts elsewhere?
We have many different causes why women are actually dying or continuing to die in Africa. Women are undernourished, so nutrition plays a very important role before you even fall pregnant. But it is also very important that before you are actually pregnant, you are in a healthy state as a woman.
Mm-hmm. Is the situation getting better or worse for those women in those areas? Because women have been giving birth for many, many, many years. Why is this such a particular problem at this time?
If you look, yes, there is some improvement, though the improvement is not as it should be expected. One of the reasons is that if you do not have education, you may not be able to then actually read. If we can improve on the literacy of women, especially in the remote rural areas, you'll find that a person is trained maybe a week course, and they say now she is a midwife, which she is actually not, and therefore women's lives are at risk.
Is traditionalism and the use of traditional medicine a problem?
In different countries, I could say that yes, it may be a problem, but not necessarily. Whilst I was still training as a midwife, some many, many years ago, and there was a very known, well-known traditional healer. The people in that village used to consult the healer before they could actually come to hospital. And what happened, the superintendent then went and visited that traditional healer, started actually giving him education about dehydration, which was killing lots of babies when they had diarrhea, signs of complications in pregnancy, and saying to that traditional healer, if you see these signs, bring them to the hospital. We're going to treat them and they will come back to you. We are not actually taking money away from you. And that helped.
Professor Rosling, while you were working on this continent, I mean, what are some of the emergencies that you saw? In what way does this problem manifest itself?
Africa will be big. It's 1 billion people today. It will be 2, 3, even 4 billion is foreseen by the end of this century. The question is if Africa will be 3 billion rich or 4 billion poor. That's about providing family planning today. Remember, China got rich after it had 2-child families. It has been big for centuries. It is also all over Asia, especially Bangladesh. It was the lowering of the number of children by the choice of the women that helped the health service to have resources for everyone. Sri Lanka is 5 times richer per person than Tanzania. Is that 5 times more money that helps, and the higher educational level that comes together with it. So dense population also help. In Asia, governments and international agencies have made contraceptives available for women so that when they choose to do so, they can have their children with longer interval or they can have fewer children. This has not happened yet in Africa in a relevant way. 25% of adult cohabiting women across Africa today want to have contraceptives but don't find them when they come to their health center. If you just would help these women to get what they want and ask for, we can take away 1/3 of maternal mortality.
Should we make contraception compulsory for women after having a certain number of children, Prof?
Absolutely not. Don't make any rules for the bedrooms. The young couple are fully capable to choose themselves. Many countries, Niger, and I think also Sierra Leone, have done an interesting thing. They've started father's school or husband's school to educate young men about contraceptive and family planning. The young couple will choose themselves as soon as you get that chance of bettering your life. And that chance is at hand in Africa now. There is economic growth almost across the continent. So what we expect in the next 1 to 2 decades is that we will see a similar fast drop in fertility rate, and with that will come much better resources.
What do you think about that, contraception as a way of giving women choices when it comes to their health and also preventing maternal deaths, especially when a woman is not ready to have a child?
I can't agree more. Indeed, in Africa, if you look at Sierra Leone, for instance, the contraception rate there is 17%. Compared to about 97% or 93% in Brazil, which is a huge difference. And I agree, indeed, a contraceptive play a very good, major role in preventing unwanted pregnancies to start with, but also spacing of the children, which is also another problem. If you are not having access to contraception, therefore also the spacing will not be correct. So the woman's body doesn't even get time to recuperate from the previous child, and now she's pregnant again.
We've spoken about unequal income distribution. Would aid be the answer?
We have to judge country by country, and within countries there are huge differences. In Addis Ababa, there are already 1.5 children per woman, and the most educated with best income in many countries across Africa, 2 to 3 child families is a reality. In the bedrooms, we are more or less the same, we humans. We think the same. And the young couples want to plan for their children, the vast majority.
Well, this is the right time then to introduce our next guest. Sanjana Bhardwaj started out as a clinician in her native India. Since then, her public health work has taken her far and wide, including the Caribbean, America, Papua New Guinea, and now Africa. Welcome, Sanjana.
Oh, that's good. Very nice.
Thank you very much. Welcome, welcome. In areas where aid is needed, what is the role of aid as a response to maternal health?
I think I would like to define this aid a bit better. You know, it's not only about monetary aid. So it's also about the technical aid, the resources, the other resources that we're talking about. And the link between what you have as in the policy documents and the guidelines to the science to the actual practice. So aid can come in many forms.
So aid would not be the only response then to this problem, because the expectation is that with the amount of aid that has come in previously and perhaps still coming in some countries, the question would be why then is maternal health in such a bad state?
It's one of those conditions that reflects a lot about a country. So it's about your health system, of course, but it also shows how your whole your whole fabric is organized. So what's the importance of women in that country, for example, in the social? What are the social norms? What are the traditions? What's the access to care? What's the health-seeking behavior? You know, do women really go to clinics, and are there clinics? So it's not just to say that you should have the health centers set up and you should have doctors in everywhere and it'll all get solved. It will not, because there are multiple factors that lead to it. And I also want to point out the burden of disease. For example, we all know the issues with HIV and AIDS. And, you know, a lot of maternal mortality, significant percentage of that is linked to the HIV virus. And Africa does bear that burden.
Why then have some sub-Saharan countries fared worse than countries like Bangladesh and India, when perhaps the living conditions of the people would be the same?
It's about how the governments and the different multi-sectoral partners come together. I mean, I have seen that in front of me in India, for example, from my personal experience. You know, you had the community organizations, you had the civil society voices, you had women's groups and self-help groups fighting for making sure that services are available. So you had that level of response. At the same time, you had the government giving its response. You had the private sector come in. You had the media raising issues and bringing out issues. You had, you know, electronics like technology coming in. So people using mobile phones to be able to transmit information and get ambulances in place. So the kind of, in the last 2 decades or so, it's been a multitude of things that have sort of, you know, you reach a sort of a momentum to a particular cause and you reach a tipping point and you're able to then see it grow and it grow exponentially.
Professor Rosling, community activism as a response. In Malawi, for example, the government worked with women on the ground and they are seeing some improvements in this arena. What is the role of the community?
It is large, you know, it is the awareness that you can avoid catastrophic outcome from pregnancy. That must be there. But that's very easy to show when you have a good service. So they go hand in hand, improving the health service and having the community aware of that. But let me say about aid. Aid is so little. It's just some $10 per person a year. And in the poorest, 2 billion when it comes to health, not more, $5 to $10. And the total health budget of the low-income countries in sub-Saharan Africa is $30. So it's very little.
Deliwe, I want to go back to what we spoke about briefly about what's happening in communities and how the problem in maternal health is manifesting itself. What is actually happening to those women who are suffering? A woman who's watching us from a privileged and perhaps comfortable background doesn't quite understand what exactly happens to women in those conditions. Can you tell us a bit more?
It's very sad because a woman dies. Before she dies, she actually cries for help, but she can't access the help that she's looking for. There is no transport. There is actually, if you say I'm sick, then you are not sick, you are pretending. When you start swelling, because now you have got hypertension, or what we normally call high blood pressure, then they say you are fat. You go, you actually are advised to rest, you are lazy. So it's all these myths and which communities out there, the leaders out there need to first understand that these actually need to be taken care of. And if women are not empowered, I understand a prof saying you need the money. Indeed, we need the money because we need the facilities for women to go. But first, we also need understanding that when the facility is there, it should be utilized. And if people do not believe in utilizing the facilities, it may be there, it may not be used. But looking at the money that Prof is talking about, that in those poor countries, the money that is there is not enough, but how it gets distributed, very little will then go to maternal and child health. When everybody else has taken a share, is then that you will think of maternal and child health spending money, which is very little.
Do you have women actually bleeding to death? Does that still happen?
If you look at the Countdown 2015 report, which is now the 2012 report that has just been produced, maternal bleeding, hemorrhage, and hypertension are still leading as the causes of maternal deaths. And in this day and age and time, no woman should die as a result of bleeding, but they are still the highest.
Mm-hmm. Sanjana, I wonder though, does having more women in leadership positions where they make policy and legislation, would that help make maternal health a priority?
It depends on evidence, and it depends on data. And I work a lot with data. I feel there's power of data. And I think it's quite proven that women in leadership positions have made a big difference wherever they've been. But to just say that because some countries do not have women in leadership positions, that is the reason for maternal, sort of having the problems with maternal health, I do not think that is completely fair. But because maybe this is the time to share. I mean, the African Union has launched its campaign for reduction, accelerated reduction for maternal mortality, the Karma campaign. It was launched 2 years ago, and it is this big commitment by all the African Union nations, all the heads of state, to actually make sure that maternal mortality is reduced. And they've doing tremendous amount of work in each and every country. I think the crux now is to make that actually happen.
We are living in a patriarchal world. You find that in many traditions and cultures, women can't even negotiate safe sex. If there's no respect for women, if we're living in a patriarchal society, can we actually expect for maternal health to be a priority?
It all goes back to the multisectorality, The position of a woman in a family and society does play a huge role, not only on maternal health, but on so many other factors, They're all linked to each other. And just the very fact that the woman is unable to sort of even decide on her own when she wants to have a baby. I mean, we were talking of contraception earlier, and many women do not have that opportunity ever to even decide that. It's decided for them. But, interestingly, I see another side of it. I mean, it was in Eastern Cape the other day, and I was meeting with this traditional leader in the field, and he's a man, and he leads, and he's, in the community, but totally in the forefront for addressing issues related to maternal health. It was quite inspiring to see him talk about it and say that I'm raising this in my community, making sure men in my community go with the women to the clinic. There are role models out there.
Professor Rosling, let's bring you in here. Those countries that have done well and have seen improvements, Are there lessons to be learned from them, and what are those lessons?
Be a little careful when you think that equity for women can solve this, because many countries with not even a minimum of gender equity for women have lowered maternal mortality. I used to be rude sometimes and said, men are interesting in delivery because there could be a boy who is going to be born. You know? So it's mother's health is in patriarchal society easier than women's rights. Saving women's life at delivery costs money, but that money has to be wisely spent, and they must be good professionals who spend that money, and there must be community action. We cannot put those isolated, they must come together. All maternal mortality virtually in the world, look down at the white boxes I placed here, is in countries with less than $1,500 per capita in market exchange rate. That is where we have it. Those countries in the middle, oh, there's a far way to go to gender equity, but it still has been lowered. We shouldn't have to wait for women's right to get maternal mortality down. That should be able to go quite fast, but you need the money. And sometimes you put too high demand on women leaders. If they don't have the money, you know, they can't go too fast. You need electricity. You can't sterilize the scissors with solar power. You need so many batteries. You need a grid and you need electricity. And for that, you need power structures. You need modernization of the country to be able to get maternal mortality down.
Professor Rosling, what is the way forward?
The way forward is the way we are on. But it is a focus not only between maternal health service and other health service, it's to reach the poorest areas of the country with some sort of health service. Often you can see capitals being relatively well served and the bigger cities and the densely populated rural areas. It to reach all the way out to the poorest people and the poorest areas. That's the big challenge.
Sanjana, what do you say?
I would say we need to up the thing on accountability. Accountability at every single level. And it also comes down to communities. So when communities take action and communities get involved, they should also be accountable for their women's health in their community, for example. In a family, take responsibility for that woman who's pregnant. Accountability in the health system side. And I agree, if the health system does deliver quality services, people will access those services. You know, it's like the sort of chicken and egg situation at times. You say the service is there, but the people are not accessing. Then you have the service, but the people access, they don't get what they want. So what comes first, kind of thing. But it's not an either or. Both need to be done.
Should we be training more midwives?
If you look in sub-Saharan Africa, which contributes 11% of the world's population, health professionals, and here I'm talking health professionals, all inclusive, it's only 3%. And of the 3%, I think it's 0.000 of midwives. And midwives, more midwives, that will be there in the communities, there in the rural areas. Because if you are in the city like now, today I'm in Johannesburg, I can access a doctor, I can access a midwife, I can access anybody. But if you go out there in the communities, rural areas, more midwives, more midwives, more midwives, more midwives.
Well, I've certainly learned a lot as a first-time mother, and I am not taking my privileges for granted. But the reality is that there are many women in different parts of the world who do not have the education, who do not have the income, who do not have access to life-saving facilities and information, and we will do well as the world to remember that. Professor Hans Rosling, thank you very much for sharing your expertise and joining us on South to North this evening. Thank you.
Thank you.
Thank you. And Deliwe Nyatikazi, thank you so much for being our guest on South to North.
Thank you.
And of course, Sanjana Badwach, thank you for joining us on South to North.
Thank you very much.
I do consider myself very privileged to be amongst a small African minority with access to not only high-level medical facilities, but also support from family and friends. This is something that all women deserve, and I commend you all on trying to make this a reality for many. That's it for today. Thank you for joining me on South to North. Please tweet your questions, comments, and opinions to @AJ South to North or find us on Facebook. Thanks for watching. Do join me again next week. Bye-bye.